All right. Thanks for joining us, everyone. 1 o'clock, so we'll get started. I'm Nicole Lee. I'm the CEO of 360 Edge. We work in the alcohol and other drug sector and in allied areas like mental health, primary care and justice. And we provide workforce development, service improvement and policy implementation in those areas. Last year, all of our clinical workshops moved to an interactive online format thanks to COVID, and it turned out to be very successful. So this year we've added this shorter webinar series, and this is the first one of those. We've got about 330 people registered, which is very exciting, but it also speaks to the topic and the guest speakers who I will be introducing very shortly. I'm just going to give a really brief overview of the report and then introduce our three guests. Then when we have some, then we'll have some time for Q&A at the end. So you can post your questions using the Q&A button as we go along. Thank you. Slides are up. All right, so before I do that, in the spirit of reconciliation, I'd just like to acknowledge the traditional custodians of country throughout Australia. I'm personally on the land of the Bunurong people of the Kulin Nation. I pay my respects to elders past, present and future, and to all Aboriginal and Torres Strait Islander people watching today. I also want to acknowledge here today consumers, peer workers and people who have other types of lived experience of mental health and or alcohol and other drug use, and recognise their important contribution to the discussion and to the solutions. If you would like a copy of the report, you can download it from the link on the left here. And also, I've been asked to do a quick ad for our online interactive workshops, which you can access on the right. Thanks to the National Mental Health Commission for commissioning the report, and also to the team that worked on this report, especially to co-author Steve Allsop, who you'll hear from a little bit later. But an extra special thanks to the key experts who spoke with us at length about the key issues and the potential solutions. Their input formed the basis of the recommendations. They came from a wide range of expert areas, obviously including alcohol and drugs and mental health, but also allied areas like primary care and Aboriginal health. And they had a range of experience, including clinical research and lived experience. As well as input from the key experts. Need to move the slides along a couple. As well as input from the key experts, we looked at the peer review literature and the grey literature. One more, Richard. And looked at current historical models and approaches from Australia and in countries with similar health systems. Okay, so I mean, it pretty much goes without saying that co-occurring alcohol and other drug and mental health issues are important to address. But we have actually been trying to solve this puzzle for the last 30 years or more. My first personal encounter with this area was in 1992. While I was doing my PhD, I started working in the acute psychiatric unit in Townsville. And because I had an interest in alcohol and drugs through my PhD and I was working in mental health, I was kind of handed this comorbidity baby. And it's a challenge that has been very well studied and the problems are well understood. And although some excellent work has been undertaken, we've never really been able to reach a sustainable resolution at a systematic level. The usual response to addressing this issue is integration. But the term has a different meaning for different people and it's used very interchangeably to mean different things. In this report, we have distinguished between three types of integration. So systems integration, which is a merger of policy, funding, budget or administration. Service integration, which merges different types of services on the front line. And treatment integration, which is the treatment of multiple problems with a single practitioner or treatment. The integration idea is repeated over and over again in official inquiries, reports, documents, most recently in the Productivity Commission report. But in business, somewhere between 70 and 90% of mergers fail. And the research says that they fail because culture, philosophy, values, and systems don't really align. And what we found a parallel in the writing of this report, that there is actually quite very little alignment of services and systems between alcohol and drugs and mental health. So in a sense, it's an approach that is in some ways set up to fail from the beginning. Problem number one is that alcohol and drugs is not solely a mental health issue. Alcohol and drug use is not always a problem, and not everybody needs treatment. So the responses that sit within the alcohol and drug specialist sector are very, very broad, from prevention to harm reduction to tertiary intervention. In mental health, harm reduction and prevention type interventions tend to be more the responsibility of health promotion organisations like Beyond Blue or Vic Health, rather than the specialist treatment sector. And in fact, alcohol and drugs is not even solely a health issue. There are significant human rights and criminal justice influences. And although these things have touch points in mental health, it's really not to the same extent as it is in alcohol and drugs. Problem number two is that the alcohol and drug and mental health systems are very, very different service systems. Kind of like trying to put a square peg in a round hole. With a large investment in prevention, supply control, harm reduction, and brief interventions in alcohol and drug, that's kind of compared to the much greater focus on management of acute crises, severe long-term problems in mental health. The clients and the conditions that are seen in both sectors are quite different. So there are high rates of comorbidity in both sectors, that's not in question. But the types of comorbidity are very different. So for mental health services, the vast majority of clients are diagnosed with schizophrenia, bipolar disorder, acute suicidality, one of the low prevalence disorders. In alcohol and drugs, although the rate of schizophrenia is higher than the general population, the main mental health problems we see are the high prevalence disorders, so anxiety and depression, also a lot of personality disorders, eating disorders, that kind of thing. The workforces and the models of care are also very different. So mental health have a much more professionalised workforce, kind of starts with doctors and nurses and with support from allied health. And there's a clear distinction between professional services and peer support services. They largely operate from a medical model compared to alcohol and drugs. We're kind of all in alcohol and drugs, and most service provision is psychosocial. So there's both a practical and a philosophical misalignment between the two sectors. It's just too much of a simplification to think of alcohol and drugs as a subset of mental health. There's overlaps in parts, but it's its own thing, really. So problem three is that systems integration in the past has tended to significantly disadvantage alcohol and drugs. What we've seen previously is a loss of funding, a loss of specialist skills, and a loss of interest in alcohol and drugs when the two services are integrated. We've integrated and separated multiple times, and over time we seem to lose that corporate knowledge that it didn't solve the problem at hand in the first time round, and in fact it actually has the opposite effect to that that was intended. And where policy and funding bodies look after both sectors, the vast majority of resources tend to be allocated to mental health. So mental health perspective becomes dominant, and then it tends to just be overlaid onto alcohol and drugs, making the assumption that alcohol and drugs is as a subset of mental health. Square peg, round hole again. Problem number four is that we know that meeting both needs improves outcomes. That's not in question. But the evidence is that integrating treatment is actually no more effective than standard care. There's evidence for people with low prevalence disorders So that's the kind of disorders that are seen in mental health services. And parallel and sequential treatment is also effective. So integrated treatment at the treatment level is one option, but it's not universally indicated, and it tends to suit mental health better than it suits alcohol and drugs. So we've got a situation, all of that put together, that systems integration tends to disadvantage the alcohol and drug sector. Service integration is not a comfortable cultural fit. The clients are different, the treatments are different, and the practitioners are different. And treatment integration isn't actually universally effective. The evidence for it is modest at best, and other types of treatment are also helpful for some people. In addition to that, people who use both services have a range of other needs. They have physical health needs, housing, homelessness, legal problems, child protection, family violence, and we can't integrate all of these services together. That's called the health sector. So this is a really great quote from one of our key informants. Why would we try to integrate those two services, those particular two services, when there were overlaps with many other types of health issues? But on the other hand, we also know that service users prefer a one-stop shop. The health system is super confusing, and you have to kind of be your own case manager in many cases. And some of our key mental health experts in particular were worried that it would be a kind of out of sight, out of mind situation. So mental health services are already absolutely stretched, and they're only responding to the most severe cases. So if alcohol and drug services aren't visible, it tends to get deprioritised in amongst all of the other things that is going on. So then really the question becomes, can we get the advantages of a one-stop shop and the integration model without the disadvantages and the significant problems that come along with it? So the conclusions that we drew were that we need to stop thinking about integration, really, and start thinking about holistic care, where we're thinking about responding to the person's needs and wants, where we work collaboratively in partnership with a range of other specialists, and where we build capacity and capability within each sector to do what needs to be done. It really only takes a slight shift from thinking I treat mental health problems or I treat drug and alcohol problems to there's a person in front of me, what do they need? So in this report, what we recommended was that to actually increase specialisation of the two sectors, integration actually decreases specialisation, and we want to do the opposite of that. Both sectors should do what they do best because they do different things. But at the same time, we also need to improve internal capability to respond holistically in all sectors, not just in alcohol and drugs. And we need to work out how to respond to the broad needs of clients, as well as addressing their immediate mental health or alcohol and drug needs. But for that to work, we also need, and we don't want to end up with just silos that don't talk to each other. We need to improve external communication, collaboration, co-location, and care coordination. The integration doesn't even fit in there because it doesn't start with a C. The question is, what does this person need, and what can I provide, and who else do we need to get involved in order to meet their needs and wants? We know this won't happen unless there's formal structures in place that enable this to happen. If we rely on who knows who informally, which is what we're doing now, pathways tend to dry up. But we can't do any of this unless both sectors are funded properly, and the funding in particular needs to go to the right place. All right, so that's a 7-minute summary of the report, of the 100-page report, but I do encourage you to download it and read it. We're going to move on to our 3 other speakers, and then there'll be a Q&A at the end. So it's now my great pleasure to introduce Jennifer Duncan. She's the CEO of the relatively new Alcohol and Other Drug peak body, the Australian Alcohol and Other Drugs Council. and she's going to give us a perspective from the alcohol and other drug sector. Thanks, Jennifer.
Thanks, Nicole. I'd also like to start by acknowledging the first Australians as the traditional custodians of the many lands across Australia from which we're gathered. I'm joining you from Kaurna land. These are lands that were never ceded, and I pay my respects to elders past, present, and emerging, and to any Aboriginal people who are here today. I'd like to congratulate Nicole and Steve for their outstanding work in the Exploring the Place of Alcohol and Other Drug Services in the Mental Health System report. It's the resource, I think, that the alcohol and other drug sector has been looking for due to the extraordinarily robust and thorough way it explores the history of past attempts at the integration of systems and service delivery in the realms of mental health and AOD, the inadequate outcomes they've achieved, and the alternative models for the delivery of holistic coordinated care that are better able to meet the needs and wishes of consumers. Its content is, I think, an absolute reflection of the deep and rigorous processes used to inform the paper, as well as the expertise and experience of its authors. I've been asked to give a response to the report's findings from the AOD perspective, and I did joke to Nicole the other day that perhaps I could just summarise my presentation as yes, what they said, but she thought something further might be required, so I've been given 15 minutes rather than 15 seconds. Bit of quick background. The Australian Alcohol and Other Drugs Council is the national peak body representing the alcohol and other drug sector, comprising specialist health services working to prevent and reduce harms which can be associated with the use of alcohol and other drugs, practitioners working in AOD treatment settings, as well as the areas of prevention and early intervention, researchers and policy specialists dedicated to building the evidence base to support robust practice and programs, and people who use or have used alcohol and other drugs and their families. AADC was formally established in 2017 following closure of the previous national peak, and we commenced operations with 14 founding members in April of last year. I've been preparing for today in the wake of a submission AADC recently put forward to a Department of Health consultation regarding the recommendations of that Productivity Commission Mental Health Inquiry report that Nicole's already referenced. Our submission primarily focused on recommendation 14, which was to improve outcomes for people with comorbidities, and its associated action 14.2, integrating mental health and substance use planning, commissioning, and service provision. It was a tremendous boon to have Nicole and Steve's work available to us as a resource in this process, and I can certainly promise you that we strongly encourage the department to use their report as an informing piece of evidence as it goes about the task of responding to the Productivity Commission's recommendations. You will no doubt hear this background to my thinking come through in a lot of my reflections today. People seeking support for co-occurring mental health conditions and alcohol and other drug use are a group that often falls through the gaps without having their needs met. And this is absolutely a systems failure that must be rectified. As Nicole has reflected upon, it's a systems failure that we have long been aware of. Evidence confirms the value of delivering holistic coordinated care for people with these and also other co-occurring conditions. Coordinated care, however, does not necessarily mean integrated care systems or services, and yet, as we know, as Nicole has reflected, as the Productivity Commission's report again demonstrates, integration continues to be the simple answer that we reach for when struggling with the complex issue of how to treat and support people with co-occurring mental health and AOD issues. The work done by Nicole and Steve captures well the long and vexed history across many jurisdictions where past attempts at mental health and AOD systems and service integration have failed to succeed against multiple measures. These attempts have largely resulted in AOD services being deprioritised and diminished in favour of mental health services, They've delivered increased cost of service. They have also resulted in a loss of specialist alcohol and other drugs practice and policy knowledge. And of course, most significantly, have delivered inadequate outcomes for consumers and communities. Integration also tends to ignore broader alcohol and other drugs policy and the full scope of program settings operating within the specialist AOD sector, including the sector's work in prevention, early intervention and harm minimisation. By focusing only on treatment requiring use of alcohol and other drugs, the integration debate runs the real risk of ignoring the remaining and important work of this specialist sector. And the inevitable outcome of this would be an increase in the problematic use of alcohol and other drugs and increased pressure on the treatment system over the long term. Nicole and Steve's work also captures the need to deliver an integrated experience for consumers, which responds to their diverse needs through holistic models of care. There is a relatively small cohort of people who experience high severity co-occurring mental health and alcohol and other drug issues who require specialist care. In the main, however, mental health issues amongst people accessing AOD services are typically higher prevalence and less severe conditions than those seen in the public mental health system. This lends itself to coordinated care approaches in which consumers whose primary need relates to alcohol and other drug use can receive shared care from collaborating services that are able to be coordinated through their primary care provider, which would be their specialist AOD treatment service. This is something that we can achieve through long-term structural and systems changes that support skills development and improve service capability across both sectors, that build intersectoral structures and practice approaches that improve collaboration and cooperation across systems and services, and which support the exchange of expertise and professional understanding between specialist alcohol and other drugs and mental health practitioners, all for the purpose of improved consumer and community outcomes. These sorts of collaborative approaches to delivering coordinated care may lack the neat simplicity of integration, but the evidence so ably outlined in the 360 Edge report demonstrates them as being more likely to be effective in meeting consumer needs and achieving positive treatment outcomes. So, a sector response to the 360 Edge report, a resounding yes, what they said. And then, given what this report so clearly demonstrates, how do we move beyond the constant cycle back to the tempting simplicity of integration to a realistic and sustainable future of collaboration? The answer must be in sustained investment and support to both sectors that helps address our barriers to collaboration and build pathways to partnership. As noted by Nicole and Steve, there are significant philosophical differences in approach between specialist AOD and mental health services, in which AOD services commonly operate within a psychosocial model of service provision and mental health services within a medicalised model. There can be issues around the willingness of mental health services to provide access and support to people currently using alcohol and other drugs. There is not always good understanding within the mental health sector of the professional skills and expertise held by the specialist alcohol and other drug sector. And each sector has very distinct and different workforce composition, conditions, and workforce development priorities. There are differences in the funding models between the AOD and mental health systems, with both experiencing underfunding, but the level of underfunding experienced by the specialist alcohol and other drug sector being more acute and more sustained. The frequent use of short-term contracting arrangements across both sectors, but particularly with regard to the AOD sector, also can tend to stifle collaboration and coordination between systems of care and foster a feeling of competition for funding. At the systems level, there's also a lack of understanding about what constitutes specialist alcohol and other drug services and treatment amongst planners and within other service systems. Too often we see poor or potentially no levels of engagement with the alcohol and other drug sector that, if remedied, could radically improve information and advice to decision makers and thus downstream outcomes for consumers. And I've got to say here, thank you to the National Mental Health Commission for commissioning this piece of work that we're discussing today. All of the above have been barriers to achieving the levels of collaboration needed across the mental health and AOD sectors. They are difficult ones to climb for sure, but they are not insurmountable. For almost 2 decades, the AOD sector has done significant work to increase its capacity to support people experiencing co-occurring mental health issues. Sustained sector development initiatives have helped AOD treatment services to build their capability to identify, assess and treat people with co-occurring mental health and alcohol and other drug issues, including through coordinated care approaches, such as the development of collaborative partnerships across AOD and mental health service providers, and the development and implementation of shared intake and assessment processes and shared treatment plans. These initiatives have demonstrated a measurable improvement in the sector's ability to deliver coordinated care for this cohort, and they give a sense of the further work and achievements that we can make in this area through this kind of approach. In the future, specialist alcohol and other drug services can also be supported to further build upon this capability through the direct employment of mental health professionals. The mental health sector also requires support in the long term to build its capability to work with people who use alcohol and other drugs. Programs that have been so valuable to the AOD sector in this regard haven't always been replicated within the mental health system. There is also work that needs to be done to identify and dismantle stigma, which is still experienced in the public mental health system by people who use alcohol and other drugs. Investment needs to be made in building understanding and overcoming assumptions regarding consumers who use alcohol and other drugs, which currently can lead to misdiagnosis and denial of care. At the macro level, and in no particular order, and again, I think very reflective of the 360 Edge report, there are essentially 4 areas in which the sector believes we need to invest to deliver the kinds of holistic, coordinated care envisaged in the 360 Edge report. We need additional funding to address existing chronic service shortfalls in the specialist alcohol and other drugs and the mental health service systems, and ensure adequate access to service for people experiencing co-occurring conditions. Mental health and the AOD sectors need to be simultaneously incentivised by governments through sustained special purpose funding to jointly develop ways of working that facilitate coordinated care provision. This needs to be done within the context of a shared vision designed collaboratively across both sectors for the delivery of coordinated care to people experiencing co-occurring mental health and alcohol and other drug issues. We need ongoing investment in the workforce development, training and education required to respectively build and maintain the capability of both the mental health and the AOD sectors to support people presenting with co-occurring issues. And we need proper engagement by governments across the specialist mental health and alcohol and other drug sectors, as well as all other areas where issues can co-occur, to design and deliver a true whole of government systems level response capable of changing outcomes for consumers and communities. Not precisely simple, but entirely within our capabilities and the most practical and effective solution available to us. Thanks again to Nicole and Steve, and indeed to everyone who informed and were otherwise involved in the development of this exceptional report. We absolutely commend it to everyone with an interest in this issue.
Thanks so much, Jennifer. Some really critical points that we can pick up in the Q&A at the end. I am now delighted to introduce Frances Cook, who is the Executive Director of Policy at the National Mental Health Commission. And she's going to give us some thoughts on how some of the ideas that have been raised fit with the Vision 2030 approach. Thanks, Frances.
Thanks, Nicole. I'm just going to share up my screen here so that everybody can see some of the vision slides. Hopefully that's working. I'd just like to, before I begin, add my acknowledgement of the traditional custodians of all the lands that we're meeting from today. For me, that's the Gadigal people of the Eora Nation, and pay my personal respects to their elders past, present and emerging, along with those who have lived experience of mental health, drug and alcohol use, and acknowledge the expertise that they've brought to this work and to the work of Vision 2030. I'm really excited to be talking about Vision 2030 and to be talking about Vision 2030 in the context of the report. Today, we really wanted to approach this with a curiosity. Vision 2030 is a project that is about looking at the mental health system. It's about looking at a systems level at what the core components of a successful and healthy system might be to support healthy communities and healthy individuals. It is imagining, I guess, if you consider a journey from A to B, then what we wanted to do is be able to take the opportunity to consider what B should look like. Quite often, I think we get caught up in what incremental improvements might be to A, where we are now. And so Vision tries to separate from current programs, current models, and just say, what are the core components that are actually needed? What are we trying to achieve? There's a lot in there, and I think, Nicole, you said it when you were doing your introduction. There's a lot in here that is not new. It's not about considering things that have not been considered before. Certainly, I've been in community and mental health services for 20 years and it's been around for that. And I think, Nicole, you had indicated probably longer still. And so there's an element to which this is also about bringing this into a piece that is designed to create a long-term plan for government and for mental health, and how that connects to a really broad conceptualization of well-being in terms of how there is partnership and collaboration across a whole range of issues, including drug and alcohol use. And so I'm going to go through and give you a really quick kind of potted description of what's actually in Vision 2030. I'll try to really highlight where we think the connections are between what you can see in the report and what we've tried to incorporate into the broader Vision 2030. And a sort of introduction of what that looks like. I appreciate that for those who may not have ever been introduced to Vision 2030 before, this will be a very elevator pitch version of what Vision 2030 actually is. On the National Mental Health Commission's website, there's a whole range of different documents, draft versions, consultation documents, and hopefully very soon the final version of Vision 2030. And so if anybody's seeking further information, you can find it on the National Mental Health Commission's website. So Vision 2030, I guess, has taken a bit of an iterative development approach. We started back in 2019 with a whole range of town hall meetings across the country in each state and territory, which was called the Connections Tour, which was really to try and ground the development of Vision 2030 in a sense of what's actually happening for people. What does this look like for individuals, for communities, for stakeholders that are providing services in those communities? And then we supported that with an online survey for people who might come from communities that we weren't able to visit, to really consider what their experiences are, where they found barriers, where they saw opportunities, and what those needs might be to create a cohesive system and address some of the deficits that we see right now. We developed a draft sort of a framework at the very end of 2019, beginning of 2020. And then last year it was really about iteratively developing that content, seeking expertise where we did not have it, exploring lines of inquiry that came up from the connections tour, from the information that we already had in terms of research. This report was very much part of that process and part of that picture, wanting to approach with curiosity and with partnership and say, we don't know, but we're really curious to find out what should this look like, not how can we improve the way, not just how can we prove what it looks like now, but what should this look like? Where are we headed with this? And then we supported that with a whole range of sort of consultation processes, some webinars and online consultation, roundtables with particular stakeholders on particular issues, sort of start to drill down into key pain points, bits where there was a disconnect between what was happening now, where we wanted to go, to really get a sense of what those opportunities are to produce the framework. So we've produced a draft framework at the very end of last year that's still going through its processes of being finalised. So we'll hopefully be able to complete that soon. And obviously, in the mental health sector particularly, there's a whole range of reform. A few people have mentioned the Productivity Commission report already. So there's a whole range of reform that's going on in mental health at the moment, that the content from Vision, the things that we've learned, this report, are going into, feeding into that reform agenda as well, and the work that's happening there. So dual processes, if you like. When we pulled all of the information together, when we looked at what Vision 2030 needed to include, there was really key obvious things, and they kind of flow from each other. So the very first was, what are the goals and principles for, what is the actual vision for 2030 in terms of mental health? And what we really took here was a sense of mental wealth, taking a positive and proactive approach, considering people and their whole needs, well-being as a really broad concept that incorporates mental well-being, that looked at the concepts of contributing life and citizenship and achieving goals, and a person acknowledged sense of recovery for people who might be experiencing mental illness, decreasing poor outcomes and avoidable harm for people who are experiencing mental illness, and a sense of understanding and acceptance broadly within the community. So senses of reduction of stigma and discrimination. There's a really long list. Again, you can kind of find that in the documentation, but that's the sort of themes that those goals came from. That's the vision that we have for the future. And those principles I'll talk a little bit about on my next slide, but really just setting a groundwork for considerations that are around people's rights, around the ways that we approach the work that we do, that should be underpinning everything from governance to the types of care and therapeutic intervention that might be provided. And then we sort of considered, if those are the goals, if that's where we're headed, if that's what we want, and those are the principles that we work with, then we really need some new approaches to the way that we address mental health, mental well-being in Australia. And again, I say new in the sense of they're not currently implemented, not necessarily new in the sense of they are new to the people who have been working in mental health and well-being and drug and alcohol use for quite some time now. But the first is taking a social and emotional well-being approach. For us, that's kind of a twofold. There's a sense of the way that we understand people, so a holistic sense of who people are, what mental health is in terms of social and emotional well-being, how that's connected to a whole range of other aspects of people's life in terms of, drug and alcohol use, in terms of engagement with the justice system, housing, employment, family relationships, social connection, and isolation. All of those components are actually integrated with each other, need to be looked at holistically and in a sense of, and I think you used the words, Nicole, partnership and collaboration. So there's the way that we define mental health and how we actually consider mental wealth. And then there's the practical consideration. What functionally does that look like to ensure that we are collaboratively as a system addressing needs for individuals and families and carers and communities? How do they actually experience a system that looks at a social and emotional wellbeing approach? And then the second for us was certainly a balanced community-based care approach. How are we actually looking to provide supports to people in what we've defined as in their context? So obviously community has a specific understanding in terms of geography, where people live and work and play. But for us, looking to provide supports to people in their context also meant communities that they might identify in terms of culture, in terms of identity, in terms of their own personal experiences. So community-based care is about providing supports across the whole spectrum of need, from low intensity to really high intensity or specialized supports. How are we creating places that people can connect with those supports that are in their context, in their community? And at the moment, quite often, I think community-based services are sort of shorthanded to mean a particular style of ambulatory care, a secondary support between primary and tertiary. And what we really wanted to get away from was thinking of a bricks and mortar approach of what community-based care looks like, and thinking about how community-based can be integrated across all of those aspects, what that looks like in terms of designing and delivering services that meet local needs, creating a flexibility in that respect. And so that's very much new approaches to the way that we want to look at mental health. And so if we have those goals and we need new approaches to achieve those goals, then we really need a system that's going to be able to deliver those new approaches. And on my next slide, I go a little bit into the detail of the kind of layers of that system that we've looked at to enable effective care, the types of mechanisms and components and the core building blocks, if you like, that make up that system to be able to deliver those new approaches. So I'll talk about those in a minute. And then obviously all of it for us very much being driven by outcomes, by trying to shift towards what are we trying to achieve for individuals, for families, for communities, for you know, states and territories, and broadly still up into the whole country. What are we actually trying to achieve with what we're doing? Very much moving away from just considering efficiency in the sense of activity and volume through to what are we actually achieving, and flexibility and innovation, I think, really coming out of those outcomes too. So a sense of how do we create it so that there are structures, mechanisms to ensure that people are receiving the best possible care they can, but a flexibility to meet emerging need, to meet needs in a different way if we're not achieving outcomes with a particular type of activity. So a flexibility in terms of outcomes and impact as well. So what that kind of comes down to for vision is a blueprint that contains a whole range of different components across 4 broad sort of system areas, I guess, if you like, underpinned, as you can see down the bottom there, by the principles of vision, looking at best practice and equality and equity, being trauma-informed and recovery-oriented. You can sort of find details of what those mean for us in the documentation, but all being underpinned by those principles. I'm not going to go through all of these boxes. That would take a lot longer than the 15 minutes. But I just kind of wanted to give you a sense of where that sits and where some of the report in terms of drug and alcohol use kind of comes out there. So the very top is governance structures. So national structures that enable clarity and consistency and capacity. What we didn't want to provide in trying to create community-based and local solutions and flexibility was 1,000 different systems. I think it's really important to have cohesion in sense of structures that enable different solutions, that enable flexibility in how things are delivered. And so we cover things like what national agreements between governments look like, what policy and legislation looks like, what leadership looks like, and in particular, what cross sector collaborative leadership looks like in terms of having leadership from mental health, from community wellbeing, from drug and alcohol, from justice, from Aboriginal and Torres Strait Islander communities, from lived experience, what leadership looks like from a collaborative sense. Investment there separate a little bit to funding models in the sense of, yes, there is the how that you deliver funding, but there's also a commitment to investing, what that looks like in terms of prevention and early intervention, collaborative practices. Standards and specifications, so setting out, ensuring quality and consistency, community design and delivery there. So very much actually acknowledging that there is a capacity building that is needed to enable services to be delivered locally, communities to be able to engage in making decisions around what their needs are, and community there, obviously that's not just, like I said, local community incorporates people with lived experience of a whole range of different issues, what local communities might be culturally or in terms of identity. So community design and delivery there is a really broad kind of concept. And then obviously working towards outcomes and impact, what that looks like in terms of evaluation, translation of research, sort of creating a culture of working towards outcomes and being able to monitor them in real time. So how we actually collect information on those. Then we've got the performance enablers. So the things that actually contribute to the success of a system. What do we need? What are the forces and resources, capabilities? I think this one is a really strong one in terms of what that looks like for how we create collaboration and cohesion, how we're making best use of what we've got to enable holistic responses to people. You'll see there integration is at the top. And so I thought I'd take a moment here to kind of redefine what we mean by integration, because for us, this isn't just about two single things that might go together. We're talking about integration, we're talking about the social and emotional well-being approach that I was talking about earlier. So we're talking about how are we enabling all aspects that respond to people's social and emotional well-being, drug and alcohol being one of them, justice, child protection, housing, employment. And so integration for us is about collaboration and partnership. It is literally looking at the distinct working parts of a system and how they fit together. And the sense of interoperability. So how are those cogs fitting together in the sense of how can they talk to each other? What does it look like to share information? What does it look like to connect with each other? What we definitely don't mean by integration here is a sense of amalgamation or merging. That's not what this is about. Integration for us is still how those separate cogs work together to create a system that looks after a whole person, not how do we create a single entity. We don't think that's particularly effective, and certainly we've seen from the report that that's not particularly effective when you specifically look at mental health and drug and alcohol. But we do think integration is important in the sense of how are we actually creating a system? How are we creating a structure that enables those two cogs to work together? What does it look like to be able to connect? How are we facilitating partnership and collaboration? How is that incentivized? What are the structures that are needed to make that something that isn't, as Nicole said earlier, reliant on individual relationship and goodwill, but is actually supported and incentivized in that way? There's some on there then that I think are fairly obvious in terms of, obviously research, a huge component, how we manage information and how that's not just what are we collecting and are we collecting the right things, but how are we sharing it and making it usable in real time across all sectors. How are we actually addressing the needs of people at different stages in terms of ages, of also people who might be in different communities, have different needs. What the funding models look like, and then going back then again to what that looks like to diversify that, to be looking at outcomes, to be looking at what it means to create some balance with block funding, with activity funding, what is the best model to create a funding environment that promotes outcomes. Multidisciplinary workforce, I think here is one that we really heard similar things and tried to incorporate some of the findings of the report in the sense of looking at what the scope is, looking at what multidisciplinary actually means, being able to work collaboratively across the whole spectrum of needs. So not just about professions have particular roles, but what are the skills needed? How do people work together? What does it mean for everybody to be working to their full scope? So are we making best use of all the skills that people have to meet needs? That includes things like secondary and tertiary consultation. How are different elements of the workforce providing support to other elements of the workforce? How are they working together, even though they might be working in different services or different systems? So multidisciplinary workforce for us isn't just about having, it's not a Noah's Ark. It's not about having one or two of each profession walking into a particular team, but it is about how we all work together to make best use of all of the skills to meet the needs of people. Certainly in there, we talk a lot about peer workforces, lived experience workforces, and a whole range of different specializations in terms of primary and allied health, in terms of drug and alcohol, in terms of mental health. So it's a really broad view of what a multidisciplinary workforce might be and what it needs. Then in terms of core components of care, these are all the essential groups of supports, if you like. Vision 2030 doesn't go into what treatment modalities, what specific programs might be necessary. It's kind of just looking at the the top level of what should be available to everybody, what needs to be considered when you're planning services, and how might that all fit together. I think here you can really see, you know, this is a vision for the mental health system. It's not a vision, we're not amalgamating what drug and alcohol looks like, right? So drug and alcohol use services aren't in there as a core component of care, but what I can really see is the connection points that create that integration. So I can see those connection points in primary and allied health and community services. I can see it where we've listed things like specialist interventions. And I know the report talks a little bit about what that might look like in terms of dual diagnosis, for example. So we've got those core components where you might see those services, but we've also got care planning and coordination as a really strong one. And in Vision 2030, we definitely talk about navigation, care planning and coordination as being something that extends beyond the mental health system and beyond mental health care to look at people's whole needs. So that includes drug and alcohol. It would also include things like housing, community services, social supports. There's a really broad range of what would be included in how you go about planning and coordination for people with mental health issues. And then delivery mediums, and we've really deliberately separated out the core components of care from the delivery mediums. For us, quite often we found, certainly we heard from people, that the delivery medium was the driver of the service that they received. So digital meant a particular thing, or telehealth meant a particular thing. A hospital meant, you know, you have a hospital, so what services can you provide out of that hospital? We really wanted to tip that around a little bit and say these are the core components of care, and then how are those core components of care actually reaching people when they need them? What does that look like, and might that look different in different states and territories, in different locations, in different communities? So we've listed some of the examples of what delivery mediums look like in terms of education and workplaces, digital and telehealth, home locations, flexible locations, hubs, so what it might look like to have co-location. That kind of connects then to community locations. So community locations for us is quite a broad category. We talk a lot about other things that are happening in a community where mental health might be important. So that might be drug and alcohol services. It might be correction facilities. It could be private practices that already exist in a community. It might be local government area services that already exist. So how are mental health services actually being connected well within things that already exist in a community? And then obviously residential and hospital. And so just growing, I guess, into that some of the stuff that came out as we were refining the blueprint identified where there might be opportunities for action. And so, you know, creating those structures and incentivizing change. And there were 6 priority areas that really came out strongly for us. And I think they really highlight the work that needs to be done. I think mental health and drug and alcohol are a good example of why these might be priorities, because improving wellbeing came out really strongly, looking at people's experiences holistically, working together, how we're actually creating what we define as integration, that collaboration and partnership and interoperability, that communication between, how we actually facilitate access. So what does it actually look like to ensure that people can access the services they need when they need them? How we actually build community-based care. So what does it look like to have those core components? How do we build core programs in the sense of case management, in terms of coordination and planning and response that are holistic? What does it look like to create community-led support services? How are we delivering personalised care? So what does it actually mean to create coordinated delivery? How are we looking at the unique population needs? What does it look like to create flexibility in delivery mediums so that we can work towards outcome and impact and not just activity? And then harnessing information. How are we actually ensuring that everyone is able to access the information they need to make good decisions, whether that be good decisions as an individual, deciding how to approach their own care needs and set goals, all the way through to how is a system making good decisions about what its needs are, where funding might go. So how we harness information. And so I've kind of tried to talk through as I was going through where those connections might be, but just to kind of sort of draw them back out. Obviously, we really think that Vision 2030 has tried to align with that concept of holistic treatment, about working in partnership across drug and alcohol and mental health, but also across mental health and a whole range of other social determinants of well-being, how we build capacity and capability within all of our health and social services, how are we creating those specializations, and how are those specializations creating connections to the broader workforce to expand the scope of how everyone is able to provide what are the unique skills that all of the multidisciplinary workforce bring, how are we coordinating care, what does co-location look like in terms of local delivery medium, and how might you create flexibility around that so it's not a one size fits all for the way those systems might integrate at a local level and how that person might experience it. Certainly when we've looked at Vision 2030, we've really tried to create an idea of how a system can create a person-centered experience, that there's a real difference, using the analogy of a stage production, I guess, there's a real difference between what you see on the front of the stage and what happens on back of stage to enable effective production. And so we really want to create a system that enables person-centered care where they can get what they need, that might look flexible and it might look different in different communities. And then obviously looking at that monitoring of outcomes and it being really driven by that impact rather than the activity. So that's Vision 2030 in a very much a truncated form, and we were really excited to get this report. We're really excited to be able to look at what this might actually mean, how this might look from an effective collaborative space, and really seek the expertise of you and those who work in drug and alcohol, because I think that's a really important piece. I think we need to come to this equitably. We've really tried to come to this from a perspective of, obviously we're developing a vision for the mental health system. It's not a vision for drug and alcohol in that sense, but we really do see an importance in looking at it holistically and looking at social and emotional well-being, and how we actually create that sense of all of the distinct pieces working together and how we create those cogs. So yeah, thank you.
Thanks so much, Frances, and thanks again to the National Mental Health Commission for funding this work. We are running a bit behind now, so I will just quickly hand over to Steve, who will kind of wrap up, and then there's a few questions in the Q&A, so Dr. Richard Cash is going to field some of those questions for us.
Thanks, Nicole, and thanks, Frances, Jennifer, as well. Look, I will do a very brief summary, but before I do, it's critical that I acknowledge that I'm over in Western Australia and on the land of the Adjunct people of the Noongar Nation. And acknowledging elders past, present and emerging isn't just an appropriate and respectful thing to do. For me, it's also a way of acknowledging that connectedness to community, connectedness to culture is a critical component of our prevention actions. And indeed, we've seen that leadership in particular in relation to their response to the risks of COVID in communities. So it's really important that when we do that acknowledgement, we recognise its connection to the work that we do. Well, the first point for me is really beware of the word integration. As Jennifer neatly said, the tempting simplicity of integration. It does mean many things, and Frances has been unpacked it in terms of what it meant in terms of the vision document. But in the alcohol and drug field, I think the experience has been one of subsuming expertise, activities and priorities within a mental health envelope. And there's all sorts of reasons why that might happen. But it has been the overwhelming experience. And I would say that as an individual who's worked in the field for 40 odd years now in different countries, but also I think the research points clearly to that. And certainly the expertise that we drew on in providing this report really pointed to that being a real concern. There are different workforces, different structures, differences in strategies. And when you join these services, what tends to happen is the larger mental health services, the understandable focus that they might have on historically poorly resource responses to acute need has consistently resulted in the experience being subsuming alcohol and drugs, not integrating, subsuming them within those services. And then there's a critical question, well, when you think about integration, you have to ask the fundamental question: are alcohol and drug problems mental health problems? And Nicole and Jennifer clearly pointed out they overlap, but they're not the same. And to give that simplicity to the complexity of the overlapping of mental health and alcohol and drug problems, which I won't go into here, it will result in the sort of nonsense that we sometimes see when we do integrate services. Where they do overlap, I think everyone has acknowledged they've not been historically managed as well as they should be, to the detriment of the individuals who experience co-occurring mental health and drug problems. But this is not an argument to put one service into another, especially when there's no evidence base that provides a strong case for this. So, and there are also very strong reasons to not to do it. They are different systems, there are different workforces, and the accounts of the experts clearly identify the concerns. And why would you simply integrate it with mental health? Why wouldn't you integrate alcohol and drugs with mainstream health, with public health, with pediatrics, with the justice system? The overlapping with the variety of needs and issues that arise for an individual who comes to someone, to an individual for treatment, or a community that demands interventions in terms of prevention, suggests that you can't just put it into one basket. And the other is alcohol and other drug issues have very different levers to mental health. Some of them overlap, but where, you know, the issues, for example, to do with prevention of alcohol problems are largely about alcohol promotion, price, licensing, hours of sale, and so on. This is nothing to do with mental health activity or expertise. And it's really important to recognize, as Jennifer highlighted, the issue is not just about treatment. The alcohol and other drug sector engages substantially with prevention. It engages with law enforcement. It engages with industry. It engages with trade. It engages with foreign trade. All of these things matter. So there are similar things, there are overlaps, but they're not the same issues. But it all comes down to this, to me, it's noted by Nicole. Alcohol and drug issues are not mental health issues. There's a person, and I would add to that, there's a community in front of me, and what do they need? So we need to recognize that there have been fantastic advances in mental health and alcohol and other drug services. I've got a particular background as the chair of the WA Alcohol and Drug Service to acknowledge the huge effort that I've seen them make in terms of responding much better to mental health problems. And I know people in the mental health sector have done the same. Mental health services need increases in funding, as do the alcohol and other drug services. Yes, we need coordinated care, but as Jennifer pointed out, not just with mental health. Yes, this needs to be resourced. Yes, people shouldn't fall through the cracks. And who wouldn't support a strategy to do that? But it doesn't mean moving budgetary, service planning, development of alcohol services into a mental health management team. I commend the National Mental Health Commission and Francis for the focus on their approach, which is based on curiosity, and it's clear that it has been. And it's been clear that they've infiltrated this principle into their work in general and their commission and response to this report in particular. We really do need to see the new approaches and development of the systems as highlighted by Francis, instead of the, quite frankly, lazy response that we've historically seen of saying we've got a complex set of issues, let's move one department into the other. That might work. Well, the evidence and our experience tells us it does not, and the outcomes are often neutral, or commonly worse. Thanks to all the contributors for the report. It is a challenging space, but if we don't hear the voices that Nicole and I and others have captured in this report, we'll fail to enhance care for people affected by alcohol and other drug problems, especially those with co-occurring mental health problems. Yes, paraphrasing Jennifer, we need resources to provide better managed care. Yes, when we need mental health to be better resourced to manage significant co-occurring mental health and alcohol and drug problems. Yes, we need resources to support alcohol and other drug responses to clients affected by mental health problems, and clear treatment pathways between the services where these are needed, as they aren't always needed. We need a workforce in both sectors better supported and resourced to respond. We need to ensure the two distinct cogs, as Francis put, work well together. We don't need integration in the way it has been narrowly interpreted. We need partnership, we need collaboration. And I'm going to quote Stephen Jerd, and I've used this quote many times since he and I chaired a committee into mental health and alcohol and drug problems for the Commonwealth about 25 years ago, which is how old I am. And Stephen Jerd, a psychiatrist in New South Wales, said, when we talk about dual diagnosis, we should remember that the duality exists in the system, not in the individual person. People present with diverse needs. Our systems should be capable of responding to these. Thanks very much.
Thanks so much, Steve. We're out of time, but there are a few questions, and this webinar is being recorded. So if the panelists are okay to stay for another 5 or 10 minutes, we can answer those questions and then people can review them later. I know that some people have to move on and go to other meetings and things, but then we'll have a record of it that they can go back to. So I'll hand over to you, Richard.
Thanks, Nick. I think getting a webinar to run on time is another example of a wicked problem, complex and multifactorial solutions. So I'm confident on today of all days that we've got a lot of politicians and policymakers in the session, very keen on extracting some meaning and wisdom from this, but I'm also aware that we've got a lot of clinicians that have come along today. So I might ask a few questions that try to span the systemic and the very practical. I guess the first one is the entry barrier issue. How do we address the which door, wrong door issue? So we assist people to get the help they need regardless of where they come. So we had a few questions in the Q&A that were talking about this entry barrier issue. And I'll throw this open to everyone, but I'm probably thinking about Jennifer, Nicole here. Feel free to jump in though, folks.
I think Steve's like jumping at the bit.
I think, and I suspect some of us are going to say the same thing. The first fundamental issue that we face as a barrier in both domains, but particularly in relation to alcohol and other drugs, is if we don't address stigma and discrimination, that these are people who aren't deserving of help. These are people who brought it on themselves. And that people with mental health problems experience stigma and discrimination, but we actually see gatekeeping even within the mental health system in relation to people with alcohol and other drug problems. And this is partly to do with illegal behavior. It's perceived as an immoral behavior. It's perceived as a self-inflicted behavior. They're not as deserving as X or Y. And if we don't tackle that fundamental issue, we're going to be having the same debates in 20, 30 years' time. So it's not the only factor, but for me, it's a fundamental starting point.
I agree with that, Steve. And I also think that if we're reorienting our thinking to more holistic care, then there is no wrong door. Like, it's impossible to have those barriers. And the problem is that we don't have that thinking now. We've got alcohol and drug thinking and mental health thinking, and therefore we say no wrong door frequently, but it's one of those things that get bandied around, but it doesn't actually get implemented in a meaningful way.
Yeah, look, I would expand upon that by saying we also talk about people-centered care all of the time, but it's a phrase that we have entirely stripped of meaning in terms of how we implement our systems. So, you know, I am increasingly of the mind that for every complex problem, there is a simple solution, and it's a solution which is about caring. And caring enough to go out of our way and step outside of our boundaries and the borders that we use to protect ourselves to actually respond to the needs of the person in front of us. So, no wrong door. We deliver that through ensuring service access. So when somebody needs to access a service, they get access to a service, no matter what the service is, because the function of that service fundamentally needs to be to help. A capacity to respond to the individual in front of us. And Steve, you were talking about that before, a willingness to see that person in their entirety, work with that person to identify what that person needs, and then facilitate that person's achievements of what they need. So it's a willingness to help meet the needs of the person in front of us. It's also then, it starts to get really practical. It's about a knowledge of and connection with other services. And then it's about a capacity and willingness to support that individual's entry to those other services through supported referral. It's actually not as complicated as we sometimes say it is, but so much of what we are capable and willing to do becomes constrained by resources that we tell ourselves it's complicated. There's a reassurance in that sometimes.
Yeah, and I would only, I think, echo Jennifer and Nicole from Vision 2030 and the Commission's perspective, that it is very much about how that system changes to become person-centred and person-led. I think quite often services are quite good at it. Individual practitioners might be good at being person-centred in their approach, but the system isn't designed like that. People still have to experience, transfer from this door to the next door to the next door. And what you want to be able to see is a system that is able to move services to the person as they have entered a door. And that's what creates a no wrong door approach. Yeah.
Francis, whilst we've got you firing on all cylinders, question in the Q&A, which is a little pointed. If the Vision 2030 focus is the social and cultural determinants of health, then why doesn't it name them?
Yeah, absolutely. And I think that's a deficit of me doing shorthand of introducing vision and not necessarily what is in Vision 2030. So Vision 2030 does go into detail on how we define social and cultural determinants of health. We go into some detail in acknowledging what social and emotional well-being as an approach might look like, and certainly how that's drawn from the experience of Aboriginal and Torres Strait Islander communities in what we mean by social and emotional well-being. We go through talking about employment and housing, adverse child events. We do go into quite a lot of depth, and I know that if I try to say that I will list them here, I will forget what is in the document, because it is such an integrated and long list of interplaying factors in an individual's life. But I certainly, once Vision's available in the documentation that's on the website, I would encourage people to read that to get more of a in-depth sense of what we mean by that in Vision 2030.
Great, thanks, Francis. I'm going to switch the topics up a little bit and talk about capability. We've had quite a few questions about workforce capability, both sectors. So maybe I could throw this question high and low and say, for the clinicians that are here, what are the implications of this report? And I might look at you, particularly Steve and Nicole, in terms of clinicians looking to improve their capabilities. And I'm wondering about upskilling and opportunities for networking or for advocacy around system change, or even their own practice. So the other part of the question might be for everyone to think about systemically, how do we put mechanisms in place to raise the tide, raise all boats in terms of overall workforce capabilities, and again, both sectors equally there.
Do you want to go or me? Well, just to start off, people do, to a large extent, what management support them to do. So it's not about running another 23 courses for people to go on and then to go back to a workplace who says, carry on doing what you were doing before, don't do something that's new. So it's about the issues to do with stigma and discrimination I mentioned. I think that has to be tackled. I think it has to be seen to be part of people's work. So I spent much of my early career running intensive training, 2-year courses compressed into 1 year, and they'd go back and the hospital would say, yeah, put the diploma on your wall, you're looking after the geriatrics this week. So, and there was a lovely piece of work done, I've gone blank on her name, which is terrible, by somebody who worked in, did some research looking at what's the role that midwives take in relation to tobacco use. This was in the early 2000s. And the principal influences was not how much training or what they believed was important to do. Principal influences were what their bosses expected them and what they thought the bosses expected of them. So we have to actually tackle the management structures and the expectations of the organization. I once heard someone say, might have actually been me, grab them by the performance indicators and their hearts and minds follow. So, you know, I saw interventions for tobacco happen within Western Australia when the minister made it legislated that you couldn't smoke on hospital campuses, and that the staff had to respond effectively and provide NRT to patients who were maybe going to have withdrawal. Massive changes happened because the expectation of the minister. So I think we have to create leadership and expectations. I think we obviously have to have training, and I think we have to have that not as post-training for people who have an interest. It actually has to be part of medical practitioners, psychiatry, nursing, and so on. And somebody who used to teach in a medical school, where people always put their hands up when you were teaching them, and they said, is this in the examination? And if they said no, they put their pens down or their iPads. So, you know, it has to be clearly communicated. This is an expectation of the job in your performance indicators, in your management support, in the training that you have, of course, but also it's seen as part of your professional role.
I also, just to add to that, I think when people hear workforce, they think training, and it's easy, we can count it, it's relatively low cost, but that's not the thing that actually builds the workforce. We need a much more kind of systemic approach, even within a service, you know, looking at what kind of model of care you have, and do you have the right people to provide that model of care, and do those people have the right skills to be implementing the treatments that fit within that model of care. And that's workforce development. It's not, training is part of it, but we also know that we can train people to the cows come home, and they tend to take one or two things, significant things away from a workshop, and then go back to what they ordinarily do. So there also needs to be structures around the work that they do to help them implement workforce strategies or implement treatment strategies and evidence-based treatment into their work. So when we talk about workforce, we need to think much more broadly than just training workshops and skills that people need. That's obviously a fundamental part of it, but there's a much bigger picture which goes to supports from organisations, systems, policies, all of that kind of stuff.
And I'd just add one other thing that we sometimes forget when we're looking at these from the outside: relationships. So as I'm getting older, I've had to use clinical services a few times recently, get bits replaced and see surgeons and so on. When I go to my GP, she doesn't get the yellow pages out or the little white book of surgeons. She tends to go to people who she's got a relationship with, who she knows, who she's maybe went to medical school with, who she's referred other patients to. And so I think that's the other thing, is how do we ensure we build relationships? There was a very good model, but it wasn't well resourced, so it was time limited, where I saw some psychiatric services run, emergency psychiatric services, run some training for the alcohol and drug services, and the drug and alcohol services ran some training for the emergency psychiatric services, and then they did placements in each other's services. And while that went on, the referral process between the two services was just fantastic where it was needed. But because it was done largely by a couple of individuals who were enthusiastic, rather than being embedded in the way in which the systems work together, it fell apart when the individuals left.
Jennifer, if you weren't going to jump in there, I might call on you, because I think there are some points you made around your kind of 4 pillars of next steps that speak to this. Someone has to pay. There needs to be a shared collaborative vision. There needs to be investment in workforce development of both sectors, and there needs to be engagement with governments. I'm just, as we're kind of talking about something that's systemic, service level, and potentially at an individual level as well, I'm wondering if they tie into some of those advocacy and funding next steps you mentioned before.
Yeah, I think they do. In that one of those areas of those next steps is very much about building those kinds of professional connections and relationships that Steve has just reflected on, which we leverage off of when the person who sits in front of us needs a service that we are not able to provide, but we want to refer them on to a known, trusted quantity whom we know will see them, we know will provide them with access, and who will deliver the level of care that that we want them to provide. And when I was listening to Steve talking about that, I was thinking about a conversation that I recently had with the president of Drug and Alcohol Nurses of Australasia, and Steve was talking about people referring people to people that they went to universities with, and the Dana president was talking to me about the potential to increase placements of people going through their nursing trainings in AOD services. That kind of cross-pollination across our sectors that builds familiarity and knowledge, but I just keep coming back to it builds relationships, and as people, as individuals within systems, which can sometimes not be as smart as we need them to be, the role of individuals to make those connections and thinking about human beings and how they work. We work through relationships, we work through familiarity, we work through connection to like, and we need to build that sense of connectedness and partnership across these two sectors. There is another thing that I want to say before I lose an opportunity to say it, and we've talked about it before. It was really terrific to hear Francis unpack that word integration. If I had one wish and desire out of this whole conversation, it would be that we would actually put that word integration aside, stop using it. It is a word that is both too open to interpretation, but also too well understood and fixed in the minds of people who are operating in this space. And those meanings and alternative forms of language that Francis used in unpacking it, I would like us to sift through those and see whether there's another phrase. Collaborative care was one that the 360 Edge report used, that better speaks to the nuances and the form of partnership that we need to see in this space, rather than continues to open up this risk of absorption and acquisition, which is how integration has too often been understood.
Thanks, Jennifer. And I think probably it's what you see is what you get for people at the coalface as well. That has a resonance for people that that work at the coalface. And I think you've done a nice job of unpacking networks there and giving a much more human face to that stuff that's often kind of lost behind a meeting facade, but that human connection component of us as professionals. Just as a bit of a meta point about, rare opportunities for cross-pollination, not only is it rare to get these kind of people in the room, but also rare that people would hang around 24 minutes after the scheduled conclusion of a webinar and still be interested in chat. We could probably go on for the rest of the day, and I dare say we'd hang on to quite a few of the participants, but I'm aware we probably all need to get back to our rich, full, meaningful lives. So I'll hand back to you, Nicole, to thank and close.
Great, thanks, Richard. And I'll just very quickly say thank you to Francis, Steve and Jennifer for participating today. I think it was a really great discussion. Yeah, we probably could talk for the rest of the day. There's a lot of other questions and a request to have another session like this. So thanks for making this a success, and thanks to all the participants as well who dialed in. And I think that concludes our webinar. Thanks, everyone.